so that we can give something to the legislature at the end of this that reflects all that, but also provides some type of pathway forward without saying it's this option.
I don't see why we can't say this option. Consensus is not the same
I'm
thing.
sorry. I want to be. I hear what you're saying, but I also am trying to say that not everybody agrees with that, and we're trying to find a way to, in this work group, agrees with that, and you acknowledged why earlier, and so what we're trying to do is make sure that that is heard loud and clear in the comments and in our report, that a huge chunk of the work group does want that, the public wants that, but there are other opinions, but we also do want to provide a path forward to some extent. And I do want to stop us because we have an agenda that we need to get through today.
And Liz, this is Beth. I just want to say, I actually have to leave at 2. And as the insurance, person in the group, I don't want you to think I'm leaving because I'm mad or offended. If I'm leaving in the midst of comments that are not, complimentary of the insurance industry, I just wanted to make that clear. I actually have to leave at 2 for another meeting with the Healthcare Authority.
So I think, as Jamie said, and again, I'm sorry that we don't have more time for these discussions, Dr. Warrenberg, but this is what we have, and what we've tried to outline in a transition plan is next steps for doing more of this work together. If you listen to Aaron and other veterans, including yourself, there was a lot of talk about needing time to build trust, and we simply have not had as much time as we needed to do that work. It's a little bit unrealistic. But we are trying to provide a pathway forward that would allow the exploration further of the 3 different models. So, but what we wanted to do in this conversation, at least, was try to bring everybody back to our goals and what we were doing here together, and see if we could at least get agreement about that, that level of work, so that when we have a conversation about transition, we can say, does this transition proposed straw plan help us move in that direction? To address those things that people felt were important. So what I'm going to do is try to make sure that we go through each of these slides and get everyone to weigh in about their perspective on this. But the point is really to try to capture the sentiment from the group. And as Jamie said, these goals were really from that work we did months ago, almost a year ago now, on what is the root cause and what is the vision for, if we achieve universal coverage, what are we going to be, what is that going to look like for us? So I just want to reorient you to where this came from. It's nothing new. It's nothing that we've cooked up on our own. It really is reflecting what we've heard from all of you. So, so this was what we defined as universal coverage. And do I need to make this bigger? Because right now it's not in slideshow mode. So hang on one second. Here we go. So this is what we said universal coverage meant. Universal healthcare means all Washington residents can access essential, effective, and appropriate healthcare services when and where they need it. So does this goal, does this definition of universal coverage still ring true for folks?
There's a critical word missing, and it is affordable.
Okay. Great.
I would like to recommend, rather than access, saying coverage for, because at the end of the day, anybody can go to the ER, so you have access with or without insurance, and the key here is having coverage to be able to afford all this.
Okay. And any other comments on this one? I think that was a really good flag, because I remember when we were breaking these down, I was wondering, where is affordability, because that was, I think it was underlying, so it's good to call it out. Okay.
Liz,
yeah.
One of the things that we've learned from events this more recently, the beginning of this year, was that we need to focus on health equity and disparities, reduce disparities. We've had that discussion in several meetings, but I don't see it in our general statement. And I think it's a really important lesson from not just the effect of pandemic, but also the equity issues that have shown up have risen up to the surface this year. And it's certainly something that the legislature has an important role in. And I'm wondering if, promoting health equity and reducing disparities is more than just appropriate healthcare services.
Right. Well, and we do go into equity a little bit. So let's keep going through this and make sure that it's reflected appropriately in the overall arching statement. So
Can I make a comment before we do that?
Sure.
I'm just wondering, can we say culturally appropriate?
sure. In this
Okay.
statement. Yep. Jared, do you have that?
Yes, I do.
Great.
Thank you.
All right. Keep going. There's only like 7 of these slides. So, okay. So we tried to then spell out some of the things that we were talking about under each of these. So one of the goals was access, a system that provides all Washingtonians with full access to comprehensive, essential, equitable, effective, and appropriate health services that are affordable to everyone. So it does more in here around spelling out affordability, but I think it's a good comment to roll it up into the top one. So take a look at this. What needs to be added or addressed here? Are there any?
So Liz, I
Sure.
mean, one thing that I did note is that the reference to effective and appropriate healthcare services, and just trying to think about how we can get at the concept of sort of a way to identify low value services or somehow beef up or illustrate what effective and appropriate means. And I'm not suggesting use of the term evidence-based because I want to be really respectful to Vicky and all the concerns that the tribes and some other communities have about what's evidence-based for a majority white person might not be evidence-based for different cultures. But there is low value care. And given how much money we're talking about, if there's some way that we could capture that concept in this.
Vicki, why don't you go ahead? Laura, got your hand. Oh,
Thanks, Jane. We were just having a conversation this morning about how to really capture what culturally appropriate care is. So thanks to Bevan also for mentioning that. And the only thing we could come up with, because we were trying to think of a way to make it fit with the legal definition, was usual and accustomed care, which encompasses traditional healing. And but I don't know if that fits here. I know it'll be in our documents that we're working on, but to me, those are the legal words that really capture, those culturally appropriate, that aren't evidence-based practices, but are practice-based evidence. So just throwing that out there. It's the language we use for hunting and fishing rights. That's why we borrowed from that, and we're thinking about how we could bring it into healthcare.
okay. So would it be, Jane, amending that second bullet to incorporate some of what Vicki is saying here?
Because
Yeah.
Go
ahead, Vicki. No,
I think
go ahead.
there's maybe other, I only know about tribal culture. There might be other cultures that have traditional practices that maybe they bring from another country or that have been in their families or in their communities for a long time. And I think those are those low cost interventions that are really very, very useful. I remember when chiropractic, we all thought that chiropractors are quacks and that massage therapy was a crazy thing. And now look at their, coming back to that's the thing. So we want to use words that will encompass what we haven't thought of yet, or maybe the things that we still need to come around on accepting.
Mm-hmm. It sounds like you were going to say something, Bevan. Go ahead.
Sorry.
Oh yeah, I just one of the words I'm not seeing is quality care, and I think if a lot of us are wanting to move kind of away for a fee for service model and more toward, you know, global budgets and focusing on quality of care rather than quantity, that's something that needs to be articulated. And I think that probably ties into what it dovetails with what you're talking about, Vicki, in terms of culturally appropriate too. I mean, quality for me might mean something different than, you know, the Latino community or Native people. So, but I think quality is then defined by the practitioners, right? The providers, the communities. I don't know.
Well, and just to kind of flag for all of you guys, and I probably should have done this at the beginning, we would have probably had a different slide here, but the ones that are going to be the headings here, we have access, quality, equity, governance, administration, and feasibility. So we do spell some of that out more, but it sounds like maybe we need to do some more tying back and forth between these. Because I know some folks would argue that equity should be part of quality. So, for example.
Right, and I'm just thinking, like, Jane, you got my wheels turning last time when you talked about the statute of entitlement. I mean, if there's going to be some sort of language put into statute that like kind of sets the stage to create something, I think that having a quick summarized statement should include quality, right?
Okay.
Yeah.
So having it, you know, as part of the sort of preamble, right? Yeah. Okay.
Yeah, I'm trying to figure out how to balance. I mean, when I think about, and Vicky's right, because when we think about now how we think, you know, of acupuncture as more mainstream and as part of sort of a whole menu of East Asian services that we're integrating into care, that makes total sense. But and Vicki, I mean, from your perspective, your accustomed practices are high value practices, right? And so it's a question of how do we honor that, but also acknowledge the fact that, you know, there is some overutilization, there is some excessive use of low value services without assuming that something that's out of the norm is low value, because there are some things that are very much in the norm, like some of the advanced imaging that goes on, that's low value. So it's a matter of trying to make call each out, but call them out as things that are separate.
I'm curious if any of our other work group members have any thoughts on this. I know, Beth, as an insurer, you see claims and things like that, or Dr. McGowan, others.
Yeah, I can't think of the language, but I can, you know, get my hands on it of what is used in different, you know, evidences of coverage. You know, certainly on the Medicaid, there is some attempt to include particularly tribal and, you know, other culturally sensitive care. So again, I don't have that language at my fingertips, but happy to forward that on if it could be helpful.
And just to add on, you know, I agree with the comment that was just made that, you know, many of the, you know, the traditional services, including imaging, high cost and also very, very low value. And it really is depending on what's going on with a patient. And so having some sort of structure that really looks at utilization and having guidelines for what appropriate utilization and inappropriate utilization would be.
Okay. Well, even if we can't come up with the exact language here, it sounds like we have some agreement here that we need to strike this balance between, oh, go ahead, Lynette.
Yeah, thanks.
Thank you.
I know oftentimes we healthcare providers talk about outcomes as how we measure the quality, and at the same time we're talking to the client, patient, as to what do you want to see happen? Because not every time, whatever the situation is, that you're looking for a cure. Sometimes it's palliative. So that's usually something that's decided between the provider and the client. So words such as value-based, outcome might be thrown in there.
You know, on that same note, I mean, one of the concepts it's emerging for quality is to use patient-centered quality metrics.
Yep.
So not just the ones that I want to see, you know, what your sugar level is, but rather, you know, what's the quality of your life?
Yeah.
Did you recover from the surgery? That kind of stuff.
Okay. Great. This has been anything else before we move on to the next one?
Is that what's referred to as, oh, sorry, patient-informed care? Is that, Beth, maybe, you know?
I think it's related. But, I mean, I don't
Yeah,
know whether-
it's similar. Yeah, it's
Right.
similar, but I think, you know, to Pete's, absolutely the informed, but then listening to the patient on what is a successful outcome for them.
Jason, go ahead, Sherry, and then Jason, and then we'll move to the next slide.
I think it's worth taking a look at how the rest of the developed world that all have some kind of universal coverage systems, how do they handle these things? For instance, I know in England, they have a commission whose acronym is NICE, that looks at things and decides what to recommend for coverage and what to not recommend for coverage through the national health their national health service. I know, for another example, that Taiwan, which put in a universal healthcare system in about 1995, that they included traditional Chinese medicine because it's widely used in Taiwan and something that we wouldn't tend to think of. But taking a look at how these folks determine limits of what's covered and what's beyond coverage, and how to make these decisions could be helpful.
Great, thank you. Okay, Jason.
Thanks. I'm not sure if it's covered in another slide, but we call out psychiatric care specifically, but not to call out every single type of service, but is substance use disorder addressed someplace else within this slide deck, as it's an important service and is hurting our communities.
Yep. Maybe it's spelling it out because I think psychiatric care, the term, I think, well, Jane would say that more behavioral health, which would incorporate both. So we need to be mindful of that. So Jared, if you could note that, that would be great. BH that includes psychiatric and SUD. So, okay, let's go to our next slide. Okay, equity. So this is what we talked about before when we talked about equity, a system that promotes equity and access to quality care across race, ethnicity, culture, income, language, geography, gender, and other differences to reduce variance in the delivery of care and health outcomes. And this would mean a system that encourages consistent, I mean, you guys can read this, I don't need to read it off to you, but take a couple of minutes to digest it and then we'll dive in.
So I remember reading this a few weeks ago and thinking that encourages doesn't define, right? And using the words encourages is kind of empty to me. So how do we specify how to do it, right? There must be consistency, like, so anyway, I'm totally open to ideas. I just think that encourages is it's
a weak word.
Weak word, yeah.
Yeah, no, we could say, you could take it out to say that it's required and it's part of contracting if you're contracting with either a provider or an insurer.
Or provides instead of encourage.
Just delete the word encourages and leave the rest of those 3 bullets.
Okay. So we want it stronger. Yep.
Yes.
Okay.
Or even must have consistency in healthcare, right? Or I don't know, I'm not a legal mind, but I think if you have words like must or shall, those are pretty.
Okay. But this is an important goal to everyone. I just want to make sure that we're all comfortable with this. An important goal that we all share. Okay.
Is the word facilitate not strong enough? Facilitates, it's another word like that.
Okay. Jared, I'm assuming you're writing all these down. Jared is our note taker.
Yeah, sorry, I put it on mute so you don't have to listen to me type.
Okay. So just in general, that we want stronger language around a system that does this. It should be like a shall or a must or require versus encourage. Okay.
Yeah, because I think we all know that legislative language gets watered down as it goes through the process. So if we start with something really strong, we can end up with something that's good enough.
Sure. Well, and if you see on the bottom, it says this will require, we were putting this together, incorporating equity and cultural responsiveness into contracting, training, and provider access standards, because that can be put in there.
Mhm.
So, and I know, for example, our friends down in Oregon recently did some work with their new CCO contracts in Medicaid, specifically related to equity. So,
Yeah, and I know the ACLU and some other groups are working on a bill this next session for equity training and for providers. So this would, I think, would be very complementary.
Yeah.
Language. Yeah.
Liz?
yeah, go ahead.
So we had several discussions over the past few months about social determinants of health, and including housing, and this certainly lists income, but I'm thinking that was a major issue in several discussions. Should we be stating that healthcare systems should address the social determinants of health? And I'm not sure if it's where it states in here, but this seems, in discussing equity, seems like a place where we should define that there are protections or a policy against discrimination.
Mm-hmm. Okay,
Like
so
a
some protective
process.
language. Yeah, and I think to your first point, so we'll potentially add some language around protections in addition to something around addressing this in contracting and training. It would be incorporating protections. I think the access slide before was the one where maybe there would be something around, are you saying a system that provides support for social determinants of health? Is that?
I don't think it belongs under access, but
Okay.
I think it's something we should be specifically stating in our recommendation, that we address, each of the aspects of the healthcare system include addressing.
Okay, maybe that's in the front in this one.
I think it could certainly belong under in one of the other subcategories. Is the final statement going to include some of the discussions as we go through each of these slides or each of the different areas?
Yeah. I mean, I think maybe we should come back to this front one after we go through the subcategories to see what we need to pull forward to really beef it up here.
And just final comment was, instead of encourages, I think we should say that the system promotes or provides, not promotes, but provides consistency, provides culturally responsible care, provides transparency.
Okay. Yeah, and one of the pre-reads, I know there was a lot of information that you all got from us. Some of the pre-reads that we sent were focused on how equity could be potentially, examples of how equity has been addressed in other systems through contracting and reviewing things with an equity lens and things like that. So there are many examples that we can pull from on this one, I think, in particular.
So
I see you looking, Bevan. Go ahead.
Oh, I was just gonna say, it's Ronnie, I think what you're saying is great. On bullet number 3 under this means the system, transparency of health quality, including reporting of adverse events, and includes information from social determinants of health, right? I think if we have clarity and transparency on, I mean, quality is informed, I think, in part by the evidence that we, or the information that we
Have in
get
front of us.
from social determinants of health. So, I mean, and they're all interconnected.
So something about if we have if we have more data and quality that includes information about SDs, so social determinants, then we're able to actually, okay, that's great. That's a really concrete suggestion. Okay, anything else before we move on to our next section, which is governance?
Well, I'd like to do a shout out. Yeah, I agree with Ron and Bevan about social determinants. I don't know if we want to hide it or put it in with the third one or make it its own bullet item. I've been reading different articles that even part of the healthcare reform would be putting money towards correcting some of the social determinants. And it seems like we heard the speaker from Oregon speak about that. So I think that's huge. And the second point is transparency. That word is pretty powerful. We've been using it and we should continue. There's a bill that went through the session this last time and that will show up again this session in the legislature. And it's talking about healthcare system transparency. In being on our PAC board, a lot of our Democrats and Republicans didn't quite understand what that was all about, but immediately said, oh, I'm going to vote different. I'm voting for that. So using the word transparency is great. And, you know, what is it within the system, within our own individual healthcare, our treatment, our plan of treatment. Yeah. So good word.
Okay. So maybe spelling out, having a fourth bullet around SDOH, so social determinants, saying something about requires, I don't know, I don't know if it's transparency or something to acknowledge the interconnectedness of equity related to how the social determinants really impact that, or something. I can't come up with the exact word right now, but if somebody comes up with something,
good,
shout it out.
And does anyone, I feel like there was a bill or a commission set up in the last year or maybe the last 2 years to get more in-depth studies around social determinants of health in Washington State. Am I?
Well, I mean, for people that are Medicaid nerds, and I'm waiting for Sean or Jane or somebody to chime in. A lot of the Medicaid transformation waiver that the state is doing is all about trying to figure out how to move money from the traditional healthcare to. So it's a big challenge.
Yeah, so maybe that's a nod. This is where we kind of nod to that, like, cross-agency work, right? Or research or something, like incorporates, I know the BREE Collaborative does a lot of work in that area too. So anyway, I'm kind of brainstorming ideas on how to kind of bring things together.
Yeah, okay. Go ahead, Vicki.
And I think with the social determinants of health, it's that the healthcare providers are connected to the systems and know when people are referred and know if they actually follow through with their referrals, and then that becomes a part of their care. So maybe it's that the social determinants of health is a part of the healthcare system or is a part of healthcare planning.
Yeah.
I think it's important to call out that the healthcare system is communicating with the social. Yeah, that's connected. Okay. There you go.
Right, but I think it's. I mean, Bevan's right. One of the key components of the Medicaid transformation waiver is the foundational supports, which are supportive housing and supported employment. And so we're acknowledging that, and I think this does go with equity, that investment of healthcare dollars into meeting basic human needs like housing, like access to employment, are a worthwhile investment because ultimately they increase the likelihood of improved health status. So
exactly.
Yeah.
I just want to point out that what you all are talking about is a paradigm shift. a paradigm shift of our healthcare system away from a business for profit, or maybe not for profit, but a business model of selling healthcare to a patient who is buying the healthcare. The rest of the world views the healthcare system as part of a social infrastructure of the country, and therefore it blends in with housing needs, job support, and other kinds of social support, what we're calling social determinants of health. If the healthcare system should become a part of that, and in order to do that, we have to shift to thinking of it as part of our social infrastructure and get away from thinking about profits and so forth.
So I think that if there's some bullet around here, I think this was really a good conversation. Something around requires or promotes or establishes a stronger connection between healthcare and community-based or social things like housing, basic needs, to promote equity or something like that.
Right.
Something that gets
Social
there.
infrastructure. Use the words that connects with social infrastructure.
Or to basically connect meeting basic human needs with improved health.
Okay.
Right.
Okay. That's great.
On this governance slide, on the first bullet, I would suggest saying ensure transparency and accountability in how the model is governed and administered.
Okay. Great. Thanks for kicking us off. Jared, you got that. So this is our next slide, which is about governance. And I did want to acknowledge what you said, Bevan, about the transparency bill, because I know Representative Macri talked about two things at the last meeting? I've lost track with all these meetings in the last month and a half. But I think one of the things for you all to think about for the next conversation around the transition stuff is how do you harness what's going on out in the other, something else, some other effort that would actually contribute to where it is you want to go. So anyway, go ahead with the others. Please chime in here on the governance, what else we need to add or adjust in this definition, this goal. I know we talked earlier about patient voice and the person being at the center. Didn't mean to move here. There's a bullet there around that.
As a physician, my eye immediately falls on respect the primacy of the patient-provider relationship. After all, if you look at the over 2,000-year history of healthcare, it is all built around patient-physician relationship. They didn't call them providers then. And yes, I understand it's broader than just physicians. So I didn't mean to get into that. I just meant that is the center. And other countries that view the healthcare system as providing this for the entire population, they don't have as much trouble with it. They just respect it. And you also will have less problems with low value care if you encourage physicians and other providers to adhere to their professional oaths and responsibilities to put the patient's interests first.
So Dr. Weinberg, are you saying that instead of just respect the primacy of the patient-provider relationship, would you want to say something about that being the center of it? Or is there something you want to change here?
Oh my, I wasn't really thinking of changing it exactly. I was just really focusing on it, but maybe it should be centered on the primacy of the patient provider relationship.
Okay.
Liz,
Go ahead, Ronnie.
the opening sentence or goal does say ensures person-centered care, like Peter brought up, like Sherry is talking about. So I think that is clear.
Okay.
And
Do we, that's great. Thank you for calling that out. Do we like, I mean, I think going to our last conversation about the connection between community supports and healthcare, we have this called out, community-based organizations are part of the governance here to hopefully take that whole person approach.
Liz,
Yeah,
I think
please.
that bullet is important, but it's really awkwardly worded. Maybe take out one of the includes. I think
Sure.
is
Yeah.
you said
Okay.
is part of its governance instead of included.
Okay, perfect. Thank you. Okay. And Jason has just pointed out that for transparency, the Drug Price Transparency and Healthcare Cost Board were recently funded in the last legislative session. So thank you, Jason. Anything else we want to change here or is missing?
So Liz, I just have one question. There's some, and it came up a little, I don't know whether we want to deal with it here or in the transition plan, but the Healthcare Transparency Board should be established and has its own time frame for coming up with, for example, the cost growth benchmark. And that's in law. It is going to be happening. And I'm trying to figure out how, whether it's a goal with respect to governance or whether it's somewhere else in the goals, that we're building on the work, such as the work of the Healthcare Transparency Board, because I mean, cost is clearly an
Big
important component of all of this. So I think legislators would be more receptive to it if they saw it reflected in the document, the work that they've already done.
Okay, that's great.
And that we know is going to influence what might happen with implementation of something like this.
I see Jason had his hand up and is nodding. Go ahead, Jason.
Per usual, Jane said it better than I did, but I just would double down on what Jane had to say, that putting something in there about the healthcare cost board is something that is language they're already familiar with and would be more effective.
That's great. And actually, I do want to point out that there, on the equity issue, there was also some work done last year on that. And I think there's some ongoing efforts around establishing an Office of Equity at the state level that could potentially also be leveraged in an implementation. So,
and then also all the prescription drug reporting that's going on. I mean, that's all about transparency.
Okay. Great.
Which makes me wonder if there's something in here needs to be articulated around bargaining and prices, reimbursement rates in terms of governance.
Okay.
Because I think that is addressed in the statement on administration.
Okay.
Goals.
Okay.
But it does, this transparency board, I see it as morphing into our own version of NICE, of negotiating prices and deciding if you're going to charge that much, then we're not going to include you. That kind of thing. That when we become the 1,600-pound gorilla in the state of Washington, we will be negotiating from a point of view of power in keeping costs down. You see, when you make that paradigm shift, you're not worried about prices, you're worried about cost. What is it going to cost the state of Washington to pay for the healthcare of everybody? And that has to do with negotiating the costs with all the providers out there. Okay, what does it cost you to do this? We'll pay you that plus 5% handling fee. That kind of negotiation is different than just being told what their prices are.
Yeah, so maybe a separate bullet that says rate setting based on information from, the Cost Transparency Board.
Okay.
Something like
well, and I have to move us along. I just got a little note saying that we're going to get kicked out of here in a little bit. Jason, go ahead, and then we'll move on.
I don't want to, I think we should just move on. Sorry. I mean, part of what's being said is happening now in the way of managed care rate setting, but let's keep moving.
Okay. So our next one is quality. We have quality, administration, and feasibility next. And I know we talked a lot about feasibility, I think at the 2 meetings ago, but so let's just get through quality and administration to the extent that we can. So I think this was very much related to the conversation we had earlier. It ties into some of the conversations around equity and access. So system that promotes the consistent delivery of quality care. It's also related to transparency, I think, from our last conversation, from our last slide. So anything that we want to fix here, adjust, take out?
You know, in addition to quality of healthcare, the point was made earlier that the whole goal is to improve patient outcomes.
Okay.
So not just saying, you know, we did that really well, but the patient not so much.
Okay.
So really to specify that the patient is going to be the measure of whether we succeeded.
That's a great comment. And you're right, I don't see that in here. So something that really calls out that quality is determined by the outcomes of the patient and that they're determining that, they're helping to determine that. Okay. And it requires lots of transparency, which, as you all pointed out, is going on in many places. So we'll need to tie into that. Okay. Anything else? Okay, let's move on. And if you think of something, you can always email afterwards and let me know. So administration, an administratively simple and efficient system that manages costs effectively in a way that promotes value. So, take a second.
I want to think
on
about
Go ahead.
administratively simple, efficient, and transparent system.
Sorry.
Somebody has a dog. Okay, so go ahead. So administratively simple, efficient, and transparent, Jane.
Yeah.
Okay. Everyone okay with that? Okay. And you know, it's pretty clear what the system what that means, but I think some of the requirements are interoperable data systems. I think that that's actually in some ways related to the whole connectedness between the community-based organizations and healthcare system. Data sharing and greater data portability. And I know there's lots of work going on around there, and I don't know if anybody wants to call anything out specifically.
So is this a point where we should call out robust funding, that, you know, that's what's going to make a system able to make decisions based on people's health rather than based on market budget constraints, that we have that as a center, having robust funding?
To do this, there needs to be funding in order to do
I
that.
think is
Right.
the word that you know, we often use, and that I don't think it was included in the opening statement. You know,
No, it wasn't. It wasn't.
A simple opening statement. You know, having a sustainable system should also, perhaps in the administration of the system, we should say that, you know, decisions will, you know, protect people's health, that has to override these budget issues. And I think legislators are currently saying, we learned so much from the last recession and budget cuts that we destroyed our behavioral health system. It's taken years to even get to the point that we are now, years and legal procedures. I don't know what to put that in, but I think that sustainability needs to be a part of this discussion.
Okay.
I'm sure that's an issue that legislators will bring up. So I believe we should address it.
Okay.
The elephant in the room type of issue, and say that,
So,
you know, that decisions should be based on protecting people's health rather than
right.
market incentives.
So basically spelling out in here that it's going to cost money.
or building that into the system. We're already spending the money.
Okay.
And it's occurring to me, Ronnie, now that you're talking about that, in terms of the administration, I'm not seeing, I saw on the 4-year plan that you guys sent out, but I'm not seeing it here. You know, a need for administrative support in acquiring federal waivers or federal funds,
Okay.
like some sort of revenue team.
A revenue group, somebody that focuses on that. And I think in one of the multiple transition documents, there was something about examining financing and all that. So spelling it out in here. Okay. So this would require obtaining revenue through, okay.
Yeah,
You got that, Jerry?
Consistent revenue review, right?
Yeah, I
Okay.
mean, you know, so is it, bad way to paraphrase, but need for outlining revenue sources while maintaining and maximizing existing revenue sources? Is that, I mean, I don't want to put words in your mouth. I'm just trying to capture what you're getting at. Okay.
Yeah, I mean, in terms of an administration of a statewide system, you're going to need a revenue team.
Yep. Definitely. Okay. Anything else before we move on? Okay. Feasibility. A healthcare system that is politically and administratively feasible and implemented in a considered way. I think we did spend a lot of time at the last couple of meetings talking about that to some extent. So just take a minute to look at this and any things that we need to change on here.
This might actually, in terms of feasibility, this might be a good part to refer to ongoing efforts like the Healthcare Transparency Board and the Prescription Drug Transparency things that are going on. I mean, I just pulled up the bill, so I would remind myself that the board, as of August 1, 2022, should be establishing the healthcare cost growth benchmark for the following year. So integrating that into the administration.
Okay.
So just a point of clarification for me, and people might feel otherwise, but this slide feels to me like a process slide in terms of, you know, how do we get to option A rather than necessarily an integral part of the system itself. And I wonder if that's something that we should delineate a little bit, or do other people feel differently?
So Bevan, I'm speaking to you as somebody who's been doing this for way longer than I want to admit. But I mean, feasibility, political, administrative is inescapably sort of a core issue that needs to be addressed, I think.
Yeah, I agree. I mean, it's unfortunate, but there are a lot of fears, a lot of misunderstandings, and you know, there's a real impact on transitioning to a universal healthcare system that is not, you know, insurance based. I mean, there's a lot of people that, you know, earn their livelihoods. So it's being able to address the fears and even come up with thoughts about how you would mitigate the transition period would be important.
Yeah, that's a good point. We haven't at all talked about a just transition and making sure that our union workers are included in this, or if there's any sort of retraining that needs to occur.
Well, and I'll just say, so we've been granted another 5 minutes for our conversation, and I think it's a little bit, I mean, just from reading the summary from a couple of meetings ago, there was a lot of conversation about how do you build something that, for example, the Medicare issue, how do you build something in a phased way that moves forward, but also allows the space for things to be changed down the road? Or how do you think about when there's going to be job losses in one area, how you retrain people for the new system? So I think that's what we're trying to capture in this slide, both as an end goal, but also I think to your point, Bevan, also laying out some of the things that need to be considered in that.
Right. I think I agree with Bevan that this is really more of a process slide of how do we get from here to there.
Mhm.
And then it is laying out sort of directly feasibility. This is sort of how to make it feasible rather than to say it is feasible or it isn't feasible.
Right.
And I've been through all of this 20 years ago when we wrote the Washington Health Security Trust Bill. And the federal waivers are very important because they include an awful lot of money, which we have to have if we're going to have if the system is going to be affordable. So we have to have a friendly administration in the other Washington, and we have to make use of it, and that takes time. So we can lay the groundwork here and encourage the legislature to pass a law that sets up option A with a roadmap to get there. But we'll have to go through getting these waivers in order to get the money that we'll need rather than trying to finance the whole thing ourselves without federal money.
So Liz, I want to go back to Bevan's comment. I
Sure.
think it's worth adding in the sub bullets under the second bullet, a reference to, individuals or workers whose livelihood would be impacted by transitioning to a new system.
Okay.
And just really call out that, because it,
Yeah.
unless we
There's an
pay
impact.
attention to their needs, but unless we pay attention to their needs, then what we're doing essentially is creating a group of folks who are going to oppose it just
Yeah.
because their own livelihood is at risk.
Absolutely. Okay, so adding a bullet around that, and so Jared, you got that, and I think that what I'm hearing, and I don't know if this captures it correctly, is that this is a goal in the sense that our work group has a goal that it's feasible. But for example, if you were drafting some type of legislation that would get spelled out around the goals of universal coverage, this wouldn't necessarily be an end state goal. This is just part of a work group goal.
It's the process goal. Yeah, it's like saying,
process goal.
Hey,
Okay.
In my mind, I'm thinking the feasible system is the system that is clear, it's transparent, it's simple, blah, blah, right? How do we get there? Well, we have these political obstacles, right? We have these administrative obstacles. This is, to me, this is the roadmap of saying, we need to, like you said, Jane, like acknowledge the fact that this is a really big thing, right? And so what's the process? Well, step one is we got to make it politically viable, right? Type of thing. So yeah, I guess that's where my mind was at with it.
And Jane, you also recommended earlier, or we're suggesting that the conversation we've had on a couple of these slides around, leveraging existing work and calling that out as like a building block to this could get called out here.
Agree.
Okay, great. Okay, I'm pretty sure that's our last one. Let's go back to the front just so that we can look at this one again and think, given everything we just talked about, is there anything in our definition of universal coverage that we need to address? We talked a bit about culturally appropriate or culturally attuned care. I don't know if that was what we wanted to spell out. Jared, what did we say back here on this first one? Did we make any changes here?
Yeah, so we're missing some critical words. Affordable, instead of using access, use coverage.
Okay.
Focus on health equities, reducing disparities. It's important to include a statement of equity throughout, so in other areas. And then lastly, incorporate culturally appropriate.
Okay.
Did I get all that right?
That's what I recall. Others, was there anything we're missing here? Before we get taken out of here in 55 seconds? Well, I hope this is, okay.
Not on this page, but I realized I'd written down trauma because I think a universal healthcare system needs to address trauma if we really want to get anywhere. So I'll be sending a comment as soon as I figure it out.
Okay, yeah, no, a trauma
but if other people can think of, yeah.
Yeah, a trauma-informed system is important in the way that work is done with patients. So,
And especially timely during COVID.
Oh my God, yeah. I'm traumatized by my children, making me teach them. every day. Well, this has been really, really fruitful. I hope it's been that for you, and I think it'll be a nice segue into our latter conversation. So thank you all for sharing, and we'll talk to you in just a minute on the other side.
Thank you.
Hi again. Y'all there?
We're here.
Oh, great. I just was having a little technological snafu, so hopefully it's fixed.
Hey,
It's
Liz,
good to
are
see you
you recording? I see that it's recording. I didn't hit record.
I did not hit record, so maybe it's you again.
It must have just did it automatically.
It looks like it's recording, as long as it's being recorded.
Okay, good deal. I won't touch it.
Okay, yeah, I see that red blinky, so it's working. Thanks for indulging our technological stuff. So let's see, let me get to this slide. So hopefully you guys all had a chance to review the multiple views of a potential transition plan. And I just want to give a little background on this. You know, we drafted this based on the conversations from the last two meetings where we heard a number of people say, I want to think about how this would look. How would we need to transition? You know, seeing the example that Jane gave of the kids coverage expansion coverage. I can't even think about that. I'm sorry. And then Aaron also chiming in about his experience as well. And I think we heard it through some of the recordings and the testimonies that were shared by our veterans of these efforts. So we really tried to pull something together for people to react to that hopefully is a way that we can move forward towards, even though there's not consensus about a various model A, B, C, it's a pathway forward that is addressing the goals and components that we just talked about. So that is really what we're looking at. And I know it was a lot, so I really do hope you had a chance to look at it. But in case you didn't, I have a simplified version I'm just going to throw up on the screen, and hopefully you all have a printed out version or something. This is really, this is the work stream version of it. It doesn't, for example, though, call out for specifically things like in work stream 1, protect coverage and reduce on insurance. It doesn't specifically say that in the first of the upcoming session, you know, make sure no cuts are made to existing programs. So it just is trying to speak at a high level about the different things you would want to do. So I just, again, we're not going to have consensus on everything, but we want to get some direction from you and be able to, you know, put something forward that we can include in the report. So the plan articulates a multi-step process for achieving universal healthcare. Do you agree with this strategy, and why or why not? That's my first question for all of you. So do you agree with this approach?
Specifically, the approach of having a multi-step, like, let's say,
Yes.
4 or 5 year process.
Yes.
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 I do.
Not the details underneath, but just this general idea.
I agree.
Yes.
Okay. Okay. This transition plan includes interim steps to fill existing gaps in coverage on the way to full universal healthcare coverage. In earlier work group discussion, some of you expressed concern that taking such an approach could reduce or eliminate momentum to achieve full universal healthcare. Do you still have this concern? Why or why not?
I think it will be important for us to include a statement at the beginning of our report that says we find healthcare to be a human right and therefore a responsibility for our society to make it happen. Better language perhaps, but something like that. And then that makes it clear that the interim fill the gap things that we do to ease some of the suffering right now is not the final thing. That we're on our way to something that really will embody everybody in, nobody out.
Well, and expanding on that, I think it's going to be very important to have a clear communication plan because, you know, this is highly complex. I mean, we've been living with it for a long time, and especially working on various approaches. And people out there are terrified. They're terrified if they don't have coverage. They're terrified if they have coverage and they're worried about it being taken away. They're really sensitive to misinformation. I talked about that earlier, but you know, things like, you know, what it is and what it isn't is, you know, socialized medicine, which is the first thing that's going to roll out. So really being able to, you know, make this as clear and simple as possible, you know, making the case for why this is important for each citizen and for the state, and literally holding their hand as they sort of walk through it. There is a risk that the longer you drag out a transition, the more vulnerable it is to get taken apart.
Right. And for that reason, I would favor something shorter than 5 years as an implementation. We want to have it before government can change in the other Washington and take it all away, for one thing. And as well as things in our state, which is what happened before under the Health Services Act of 1993. Political shenanigans emanating from outside or starting outside our state came in and were amplified by actors who will remain nameless, and destroyed the Health Services Act of 1993. By the way, if that had been allowed to be implemented, we would have had universal coverage of some sort by 1996.
Okay. Other comments on this one? Dr. Weinberg, you mentioned calling it out in the report. I think in the transition plan that the straw, I'm going to call it a straw person that we put together, we have legislation that sets a 5-year goal. So not just in the report, but also legislation that clearly states this is the end goal for us. Jane, do you want to say anything? I see that your mic is now unmuted.
So 4 or 5 years sounds like a long time, but I got to tell you that when I was looking at version 3 of that transition plan and looking at how many months there were to do massive pieces of work, 4 years seemed short. So the reality is this is a massive endeavor. And if you want to do it in any way but behind closed doors with a small group of people deciding what's going to happen for everybody, democracy is messy and it just takes time. So, I mean, that's because I think one of the positive things, yeah, the political winds changed and HSA the Health Services Act met its fate. But I think one of the most positive things about it was a lot of work groups and a lot of people participating, but at least people felt like they were heard and they had an opportunity to provide input. And the other thing that I would say is I agree with Sherry that the political wind could shift. But to Dr. McGuff's comment, if there is not some bipartisan support for doing this, then the risk is that you're going to have exactly what happened in 1993 happen again, because there was not a single Republican vote for that bill. And I remember a very, very ill Democratic legislator having to come in and vote because every Democratic vote was needed. So the reality is you want something that's going to endure beyond the political winds.
Yeah.
So that's
Vicky?
the old lady talking again.
Oh, it's Vicky, Ronnie, others?
So I really love this statement in that report from the Office of Health Equity about the fact that the legislature is different now. We've learned some things and our awareness is so much higher. You know, we don't need to steal the statement from them, but I think we should be realized that yes, winds of change could, or you know, there could be Republican, Democratic changes, but I think the changes or the successes that Healthcare for All Washington saw in the legislation or the short session this year were dramatic, that Republicans and Democrats were voting things like unanimously on cost transparency issues, on other healthcare issues. So I agree that there may be some barriers ahead, but I think this is the perfect time for us to be making this recommendation. And I think we should state that you know, there are lessons we've learned from Black Lives Matter about health equity for all. There are lessons we learned from the pandemic about economic disparities. And this is just a great time to be doing this and to moving to the next step.
Bevan, Vicky, anything?
I just agree that it's important to like ride this kind of sweet spot in time where equity is really at the forefront. But I think about a lot of the failings of the Obama administration with the Affordable Care Act. They let other people control the narrative about the Affordable Care Act. So I think it's really important for us or the state to really have the PR piece, the education piece. Don't let somebody call it whatever they could make out of Ainsley's name, you know, socialized medicine, because it really is about equity. And I don't think there's any evidence that allowing everybody to have equal access to healthcare is going to take away from anybody. Things will definitely change. I mean, I think about the people who work in the insurance industry. What if they worked in public health? What if, you know, that was what they got to focus on, helping people be healthy instead of denying claims, you know? So I think if we can do the PR right, we have a better chance of having that longer time to set it up and make it work right. Sorry for talking so much. The biggest failing of the Indian healthcare delivery system, which is socialized medicine, is that it has been chronically underfunded since 1955. And that's where the health disparities come from. So we have to make sure that the legislators buy off on it and are going to be able to help us keep it funded and that it's sustainable as well. So I made all my comments at once, I guess.
That's great. Anything else on just whether or not we like this multi-year approach?
I was just going to say super quickly that the steps to expanding coverage in my mind, but they have to be building blocks, right? It has to be this expands to this expands to, you know, on the way to, because otherwise in my mind, I do think it's dangerous to say, oh, we're going to invest millions of dollars over here in this program. And then you start bifurcating the revenue and, you know, all of a sudden you're headed down a road that is going to lead us to where we are now. So in my mind, it's as long as it's clear that it's a building block, I think that that's necessary.
Well, and Bevan, one of the questions that I have wondered about, and you brought it up last time, and again, it was more homework for all of you, but was the issue of the Cascade Care and the subsidies, and how does that become a building block in this towards the longer term goal? And so how do you build it in the short term to fill those holes, but also with the end game in mind? So, okay, that's great.
I had a question. We have 4 legislators that are on our work group. I think we need to utilize them. Ask them privately if you need to. What do they need to see? how do they need to be convinced?
That's a great question. What would help them?
Yeah.
Sorry. We
Okay.
have legislators on our Governor's Indian Health Advisory Council, and we ask them right out in the open public meeting. What should we name this bill? What do you want to see as a legislator? I think it's important to understand how they're thinking, and it will really help us with strategy.
I'm wondering how much are they participating in the work group? And I think that the rest of the work group should know what their attendance has been and other participation.
Okay. Thank you for that comment. I'm going to actually move us along, and I think that Vicki, what you just said gave me an interesting idea for what we do in December, in addition to reviewing our final report. So my next question is, this work group has really served as a stakeholder engagement process, but we're going to need to do more of that. Obviously, there's just so much to do, as you saw from this robust straw dog. The transition plan proposes an action-oriented interagency universal healthcare commission comprised of key agency leadership to design aspects of the universal healthcare plan. Rather than including stakeholders on this work group, the UHCC would engage stakeholders at various points. Do you agree with this approach or not? And why or why not?
I want to hear from you, Jane. You did it. I've been talking to my husband here, getting that comment. So how did you feel?
So I staffed the study commission that developed the document that became the Health Services Act. And one of the things that I really liked about the way that commission worked is that you had a number of commissioners, and then they broke it up and had like probably 5 or 6 different work groups, each of which had a few commissioners on it. Because that commission, the Health Services Commission, I think, was only 5 members in terms of post-HSA enactment. The commission that led up to it had probably more like 20 members. But those work groups that were given explicit issues to work on, that were composed of usually a few work group members, commission members, one of whom chaired the work group, I thought were incredibly effective. I staffed the medical liability work group, and Phil Dyer was on it before he became a legislator. And those relationships that were developed among consumers and providers and insurance companies, it was a really civil discussion, and it was a really good opportunity to talk through some really tough issues. So I think it worked really well in that respect.
Yeah, I was president of Medical Association around that time, and I got to sit in on the stakeholders committee with George Schneider and some of the others. And I thought it was very thoughtful as well. I think a lot of it was how do we engage people and help them understand what this is proposing to do. And going back to an earlier point with the tide that flipped the Senate back to the Republican side, that rolled this all back, that's a risk. And so really being able to find out how rapidly we can educate and engage people is going to be key, in addition to make this work as well as we can.
Jane, one question I'm curious, and Bevan, actually, why don't you go ahead, and if I have time, I'll ask my question later. You go ahead.
Oh, I was just curious. There's always a group or somebody who comes forward and says, you guys didn't talk to me or us. Which groups that did that at that time, and is there a way that we can at least try to mitigate something like that again?
That's a really good question. I don't remember specific examples of that, Bevan. So yeah, I don't remember specific examples. We were really careful to try to have the perspectives that needed to be there, but you're never going to get everybody. I mean, one of the nice things is back in the early 90s, we didn't have the kind of IT infrastructure to be able to solicit input that we have now. I don't want to say Facebook. I don't want to ever use Facebook, but you know, there are so many other options.
So Jane, my question was related to something, I think maybe it was Dr. McGough who brought up earlier, or it was just a general conversation, was about the communications piece of it. Did you guys, how was that handled?
That's a really good question. You know whose brain you might pick is Doreen Garcia, because Doreen was she staffed Randy Revelle, because Randy was the executive director of the commission, the study commission. And Doreen was on his team. I could link you up with her if you want. Because I was so busy focusing on med-mal or medical liability that I wasn't stepping back and really tuning in on the communication stuff.
Oh sorry, my dog is barking.
I mean, to answer your question, Liz, I do support that aspect of it. And I think as long as there is, clarity, I think, especially talking to the folks who were on previous commissions to find out, what worked and what didn't work in terms of composition. And just to make sure that the whole process is transparent, and that, the people who need to be at the table to make sure that their perspectives are heard, especially minority communities of color. I mean, equity is, we're talking about all of the residents of Washington State, right? So making sure that those voices are at the table.
The Gardner Commission had 17 members, and they were mostly selected to represent political points of view. The only name that I remember, and Jane, you'll remember more than me, was Jim West, who subsequently became a mayor in Spokane, and he represented the right-hand edge of that group. But they did not feel the need to try to come to a consensus. And I believe in the end, they voted 9-8 that single payer would be best. But they also voted 9-8 that they didn't think that would ever pass the legislature. And therefore, they proposed what eventually became the Health Services Act of '93, which was a universal coverage system built on highly controlled insurance, private insurance. And I'm bringing that up on purpose because our group, we have people in our group who are paid not to agree to option A. And we are not going to be able to persuade them. There's no persuading when somebody's job depends on their being against it. But that doesn't mean we shouldn't propose option A if the large majority of the group is in favor of doing that, and we're just talking about, well, how do we get from here to there, rather than agreeing on the there. And too bad about the people who are paid to oppose it. We should take into account how to help the transition. But they're not the tail that wags the dog.
Okay. Thank you for sharing that. So the idea of having a stakeholder, having a UHCC, a commission where various members of that work with stakeholders and sort of feed up, is that how it worked with, okay, so folks like that approach, okay. Because it is gonna be like a big web going out here. So getting kind of more into the details, I guess, are there transition steps that are missing? From your perspective, we really tried to build this example here, pulling from what we heard from veterans, but also really looking at the goals that were articulated by the group around what needed to be done and what areas needed to be addressed. So is there anything that's missing in here?
So I'll go back, Liz, to what I was saying earlier. I think what's missing in here is integrating in the dates of things like the Healthcare Transparency Board cost growth target being set in August 22nd.
Okay.
Just bringing those things in where you know it's going to have an impact on potentially decisions that are made here.
Okay.
And I mean, I reviewed this. I think I liked view 3 the best because it integrated what's happening plus the dates.
Mm-hmm. Okay.
This is, I got to tell you, this is really ambitious.
It's
really.
scary, isn't it? But exciting.
Jane, I love to hear that you got into that and found that it was wonderful. You have my proxy. I got lost.
I think the other, so just to say, like, one of the things that, and this is based on my previous life that I was worried about not being in here, was really calling out the what I think is going to be in front of the legislature this year right now, which is the cuts that might be coming down, and just calling that out, like making sure nothing happens right off the bat. Because then you're having to do even more work long term. So
Yeah, I think some sort of statute of entitlement, I think, is necessary in step 1, right? And I think you could incorporate that, statement that you just said, Liz, into kind of the legislature finds, right? And one of the key pieces for me in that language is that we are in the biggest recession since the Great Depression because of a public health crisis, right? And, we find ourselves at the state level with thousands of people who are losing their insurance because they're losing their jobs. Our state Medicaid system is bowing under the demand. We have an entire undocumented population that doesn't have coverage, and the virus doesn't care whether they have papers or not, right? In order to really, one of the significant pieces that's going to get us out of this economic crisis is actually investing in our public health infrastructure. And I think that that's one of the key pieces that has to go into this statement at the very onset, which doesn't cost the state a dime to have statutory language, right? So that's key for me.
okay. Jared and Sean, you guys captured that? Okay.
I think so. I think I've got that.
So just calling out, being very specific about
The statute of entitlement, and that the current, in response to the current economic situation, that the current economic situation is caused by a public health crisis. And so really we do need to address that within that statute of entitlement, that the situation we find ourselves in is due to healthcare issues.
Are there
Yeah,
other?
think about its terminology makes a big difference. And I'm noticing that like the phase 2A and phase 2B leads into a proposal to the legislature. And, one way to think about it is are you submitting recommendations to the legislature, or are you submitting an implementation plan that you're asking the legislature to endorse?
Yes, I think that's a key difference that sometimes might get glossed over.
Okay.
Because right now the reference is recommendations.
Mm-hmm.
So it's just something to think about.
Okay.
And a lot of that depends upon how much detail there is in the enabling statute, in the original enabling statute.
Okay. Bevan, were you going to say something else as well?
I guess I was just going to ask, in terms of the 4-year versus 5-year, what was the thinking around that? And I'm just thinking about budget years and our cycles in terms of biennium, and also our 4-year election cycles at the federal level. Strategically, like talking about feasibility, right? So if we're thinking about, funding and revenue, that's a 2-year budget package, right? Then there's another 2-year budget package. So if we're thinking about like a final component, maybe that's at the 5-year level rather than the 4. Anyway, I'm just thinking about like, and also at the federal level, if things go the way that a lot of us hope they will, I think that, it's still going to take a while to get those waivers, even in a position
Right. So yeah. So you're asking like what was our thinking about that? Or I think it was really trying to think about the different legislative sessions and different ways to do it. So I mean, I think there's just, it depends. It's just a straw dog for you guys to react to and think about what makes the most sense from your perspective. But we tried to factor those things in to some extent.
I will say that given the scope of what the phase 2 bill would be, better to have it be done during a long session and at the beginning of a biennial budget cycle. So the 2023 date makes sense.
Jean, could you repeat that so I can capture that about the dates?
So given the scope of the phase 2 bill, it makes sense when you've got something that's going to be that big and potentially could affect the budget that much to do it in an odd numbered year, because you have a longer session and you have the beginning of a biennial budget cycle.
Well, and I also wonder too about, what we talked about before around strategically building will over time, so that the next go around you've built some trust and relationships and some evidence that things are going to go well. Yeah, it makes it a little bit more feasible.
There is one thing to think about. What are your assumptions around when the funding to begin enrollment in phase 1 coverage would occur?
Hey, Jared, do you want to respond to that?
Well, the timing of the funding, so it's a little bit difficult, right? Because we talked about the transition to move into the program. So I would think you would need, this isn't going to be a simple answer, but you would need the funding no less than, I would think, a year or 2 years prior to implementation. Otherwise, how do you get all of the pieces in place such that when you hit the switch and turn it on, everything is ready to go? I mean, I may be even shorting it by just even saying, 1.5, 2 years. To me, I think the first phase is, what are all of the transition elements we have to address and take care of? And then I think that input, it defines the money and then also the time that you're going to need prior to implementation. Sorry, that wasn't much of an answer, but.
So maybe I'm not understanding, because I'm looking at it says pass legislation to adopt phase 1 coverage changes for the uninsured. And that would happen during the 2022 legislative session. The value of waiting until July of 2023 is it's the beginning of a biennium. But theoretically, the legislature doesn't have authority in a 2022 biennial budget to commit itself for a 23-25 budget. So you won't know whether the funding is actually there until the legislature actually appropriates the funds. So that's one thing to think about. The other thing I'm thinking about is in the classic political dynamic of it's harder to unring a bell than ring it. One question is whether you would want to have people starting to enroll in coverage like about the time that the legislature is moving into phase 2, so that for them to go backwards becomes harder. You know what I'm saying?
Because you're then taking something away.
Right. Well, I mean, look at the fact that Congress couldn't figure out an alternative to the ACA.
Yeah.
And every year that millions of people were getting coverage through the ACA, politically it becomes more difficult to unring the bell.
Yeah.
So the only thing I'm wondering about is, and here I'm not speaking for the commissioner, I'm just speaking for me and my experience. The only thing to wonder about is whether before the legislature takes a massive leap forward on to whatever big model it's going to go to, you've got some of the key initial steps implemented.
Right. Okay. So we need to think
I don't
about,
know how other people feel about that, but.
I see some head nodding.
Thank you for articulating what I was trying to say, Jane, about the budget and the years. So thank you for putting it better than I did.
I saw some head nodding when you said that, Jane. So thinking about the timing and phases related to the budget and how, you know, just how that relates to how it will be accepted by, you know, the larger population when they need to keep moving forward. How is it a strategic move forward in that vein? I think, I don't know how to say it even better, but somebody else is taking notes here and they will say it, and you can always email me with your specific comments. But so timing, we really need to think through the timing of it is what you're saying. Okay.
Liz?
Yeah, go ahead, Ronnie.
So there, Jane's comments about laying some groundwork or creating services to build on because they're harder to take away really makes me wonder why we haven't had some experimental or some possible experiments on how to address covering people that aren't currently covered by by current programs because they're immigrants or refugees, or looking at the specific issues that address rural health communities you know, and there are waivers available in the current Affordable Care Act, which, you know, only an irrational Supreme Court would throw out because of the irrational arguments that are coming up against it. Is there some possible experiments or mini grants or programs that we could address building on those 1332 waivers in the Affordable Care Act?
Well, I think, I don't know about I mean, the 1332 piece would take a little bit longer, but I'm, you know, wondering about two things that come to mind right now. And it goes back to something that I mentioned earlier, was the whole Cascade Care subsidy study and understanding what could that potentially do in the short term for some gaps. Again, it doesn't address the undocumented population or anything like that, but it is an effort to try to move forward on some coverage. And how do we, I think, you know, as Jane said earlier, how do we think about pulling in other things that are being done that could potentially build moving forward here? Those are the only ones that come to mind for me right now. But so basically, are you saying, Ronnie, you'd want to have something?
I'm asking if the group has considered those options rather than waiting and having. There certainly are long-term plans which are, you know, really make sense and pleasure to see. Are there some immediate steps that we could use as experiments to prepare final steps or
Mhm.
to learn as we're developing a final plan. And Medicaid really has been a great opportunity to build unique services, and the waivers that the state has obtained and implemented have really have some great opportunities for us, or there are more things like that that be considered.
I see Jason wants to say something, so go ahead, Jason.
So yeah, there are currently some of these experimental plans already available, and I think Cascade Care starts to address the issue. But you have coverage for undocumented children today that some of the people on this work group have worked hard to get into place. But you can, and there's also been other really good work that's been done by stakeholders around extending the FPL level of some of those programs and extending out healthcare coverage to undocumented individuals, similar to a Medicaid level of service. They just have not gotten over the line as of yet. So a couple of them, one of them out there already is for family planning services that has already gotten over the line, but full coverage for undocumented clients has just not been able to have the political will within the legislature as of yet. Some of them are out there, and there's some really good ideas about extending FPL levels and extending age, taking the CHIP program out to say 26, or try and mimic what's happening in the commercial market. But it takes political will.
And
Go ahead,
a real simple one that got passed last session, not simple, but a really easy one to pass, was the extension of pregnancy medical for up to a year. And then it got axed because of the budget, but maybe that's a place to look again. I know that it's going to come back up. So that might be a good place to start, because who doesn't want moms to have coverage so that they can take care of their babies in that first year of life and not have to worry about going back to work, so they could get back on coverage and, Family Medical Leave Act and all that stuff that women have to worry about. And I think the words that Ronnie was looking for is like pilot project, maybe.
Okay. Okay.
The
So-
biggest problem with these various Band-Aids is that when they're pasted on top of a system that is so fractionated with everybody taking profits right, left, and sideways, is that it costs a whole lot more than it really needs to. I think we need to be a little careful not to put out too many Band-Aids there, so that everybody says, okay, that's done, let's go, let's stop. And the insurance companies will be right there to scream. They would, by the way, any insurance company would love it if we had universal health insurance, meaning that our government would somehow pay everybody's premiums to the insurance companies, and they would all go running to banks in Cyprus to deposit it. It's just a reminder that using the insurance companies in the middle is just way overpriced. So we would need to find some way to add these folks, add some of these Band-Aids without funneling it to too much of it anyway, to insurance companies.
Vicki, I see your hand raised. Is that your hand? Or it's my mouse. My mouse looks like a hand. Okay, there's Jason's hand.
So the CHIP program for children in Medicaid is not run by health plans. It's run by the Healthcare Authority in a fee-for-service sense. So no capitations are paid to health insurance plans. But then again, this is, we can take care of children. We need to extend that farther out in this process and make it a more robust program. Go out farther in age, higher FPL levels. That would be a great starting point. But
Okay, so I think getting back to the original comment that you were making, Ronnie, was basically about trying to come up with some or take advantage of or create opportunities for coverage, small scale at the beginning to kind of build will. Is that what you were saying?
Liz, you sound like a robot. Sorry.
Oh.
A good robot, not one of those.
We can kind of
evil
understand you.
not the evil
Oh no,
kind.
what happened? I better shoot. I'm gonna move my computer.
Something's wrong with your voice system, Liz.
Oh no. Is it getting any better?
No,
Oh no. Shoot. Jared or Sean, somebody.
Yeah. So I will try to paraphrase what I think you were trying to say, Liz. So Ronnie, I think what we were saying is you want to create opportunities for coverage in small steps as pilots in preparation for movement to larger coverage. Did that and the follow-up discussion capture the spirit of what you were trying to convey?
Yeah, and really was more of a question. I'm sorry.
Okay. Oh, no.
I'm wondering if there were, if the consultants did weigh those particular areas. And I know the legislature is working on some, and I know we have a history from implementing child health coverage, and I know we have services within our state government that are able to move forward, and why we don't have some pilot projects that will answer the ultimate question of what the big picture is going to look like. And I don't know. It really is a question.
It's a question. Does my voice sound better? Okay, I'm gonna leave and come back. Jared, please carry on. I don't know what's wrong.
Where?
We're gonna get kicked out of here in a couple minutes anyway, but I'm sorry.
Oh, lucky everyone, I get to facilitate this. Okay, so, I had my own problems. That's why I kind of fell out and came back in. So I feel for her. Okay, so pull up the facilitation guide here. So again, we just were talking about, let's see. The work group served as stakeholder engagement, but more stakeholder was needed. Did we talk about this already in terms of an action-oriented interagency universal healthcare system? Rather than including stakeholders on the work, would you engage stakeholders at various points? Did we covered that already, correct? In the part that I came into? Okay. And then, so we were talking about transition steps that we were missing. I think that's where we came up with the interim pieces, but are there other components in the process that's laid out on that slide? And do I need to share that again, that we need to focus on? Let me see if I can share it here. Well, let me do it. There we go. So this was the slide. Just give folks an opportunity to take a look at it. You all seeing it okay?
Yeah.
Yeah.
Okay.
There's a little something that popped up on it.
I know, this is,
Yeah.
boy, oh boy. Hey, if you guys could see the color of my face right now, you would laugh. You would all laugh. My apologies.
That's right. This is Kate.
Elizabeth.
Looking at it, I still don't see
Okay.
a reference to developing a communication plan, and I think that ought to be something that's done right out of the blocks.
Do I sound better now?
Yay!
You do. Everybody's
You sound
so
like a
happy you're back, Liz. I can't even tell you.
Oh, well, I had my notes included communication plan.
Yeah.
Okay.
Communication plan.
It is absolutely critical. Oh my gosh, I'm sorry that happened, everyone. Now, Jared, okay, so what else did we miss?
Yeah.
Anything? Okay.
I was going to say, is there any details about the communication plan that we need to go into in terms of what does it, I mean, it's easy to say communication plan, but do you need to, is it all refined out, or is it all
Yeah, I
detailed
mean,
out? Liz?
a couple of points. One, it's not just about the what, it's about the why,
Mhm.
the heart and the mind, and then also having it geared towards different stakeholder groups. So, the general public, including insured and uninsured, providers and hospitals, the legislature and the interests of the state, unions. I mean, it can't just be a single little ad. It's got to be really targeted on how it benefits these different groups.
Jared, we talked about a little bit about this as would it be part of the UHCC sort of structure to have some sort of strategic communications around folks? And I'll just say that Jane and I worked on kids coverage a million years ago, but one of the things we did that I thought we did really well was make sure that we were going to different groups to talk to them about why it was important to them. For example, we had Republicans in the Yakima Valley supporting that coverage for undocumented children because it mattered to their workers and the ability for their folks to work. So, so we have to do that. Yeah, that has to be done.
I think the thing I would say is it's more than just communications. It's also public relations and a campaign. We really need to sell.
We just have a few minutes, so let's do a very condensed report out. And this time, how about we start with Jared? Do you want to start with the highlights from your conversation? Oh, you're still muted there, Jared.
Oh, sorry. I'm gonna ask Liz to start it off because I was cut off at the very beginning.
Oh, that's
and then
right.
I can come in and fill on top of that. So yeah, if you wouldn't mind. Sorry.
Liz, do you want to do it, or do you want me to go over what I've got? Oh, and you're muted.
I guess I control the main room.
Okay. Oh no, sorry. It's because I got kicked out and I had to come back.
Oh.
It was a little bit of a mess. But anyway, Sean, you go ahead. I'm going to go get my notes from the other room when I got kicked
Sure.
out, and I'll chime in.
So the first point was the question, the transition plan anticipates a multi-step process. Are we okay with that? And I think the answer was a tentative yes, as long as a few things were highlighted and brought out. The first thing is that was brought up is that we would need to find and make clear in the transition process that healthcare is a human right, and therefore it's a societal mandate, that it's something that societal mandate to provide, so that was clear right off the bat. And then as one of those steps, a clear and very coherent and robust communication plan using clear, simple language that is tailored to many different stakeholder groups, including the public and hospitals and providers and so on and so forth, needs to be one of those steps. And then the other thing that was brought up is that in that 5-year goal with all those steps, it was brought up that seems like a very short period of time to implement something of this magnitude. And while it may seem like that's a long way out, when you actually start putting steps together, that is not the case. It's not a very long period of time. So I think those were some of the steps that were brought up that needed to be included in our tentative agreement that the multi-step that work group members were okay with a multi-step process.
Okay, and I hate to hurry folks, but we just have a few minutes left. So
Sure.
what were the responses around your stakeholder engagement process? Were people comfortable with a commission? Yeah, go ahead, Liz.
People liked the idea of the commission and the idea that those commissioners would stakeholder on their various issues. They really wanted to hear from folks like Jane about the process from before. They wanted to use those examples. And we're supportive of that idea.
Okay, great. Anything else from your work group you want to share before, or your discussion group that you want to share before we hunt it to Nora?
I think there was some topic conversation around timing, not so much the 5-year issue, but how do we stage things in the right order given budget years, and also making sure that the multi-year effort is also building will over time. And so those are some things we'd need to think about.
All right, thank you. Nora, you want to build on, add anything that was not covered?
Sure. Our discussion started with kind of level setting about kind of the level of detail. There was some concern that we talked a little bit about who this was a document for, recognizing it was a document for the work group to kind of think about a process, not necessarily that we would hand to the legislature, now you do this, now you do this, now you do this, given that they have some experience with that, that piece of it. So we talked some about sort of what was vague and what was detailed. We really wrestled as a group during this conversation about whether it's viable to recommend a model or lay out the perspectives. And there certainly was the perspective that we needed to make a recommendation. Others really stressed that that didn't seem like a realistic product for this group. And so it needs to more, be really clear in the report what the models, what the perspectives on those models are and details. Folks were pretty open to the idea of the commission not being a stakeholder group, but being kind of a working group, with the understanding that it would be very clearly articulated in the development of the process and the commission that there would be these specific opportunities for stakeholders to be involved, recognizing that it could be challenging, and recognizing the number of stakeholders and the amount of money that's in the healthcare system. People were comfortable with the idea of having specific ways for engagement to happen.
Thank you for
Jamie,
that.
I don't know what else I missed.
Nope, that was the only thing I would add to that is there was also, and I think this echoed what happened in breakout room 2, clarity that there would be a need for tools to support getting this universal health care sold to the legislature and other stakeholders, things like communication tools, which sounds like something that was talked about in breakout room 2. Janine, you're up. What would you add that's different from what happened in your room?
I think that one of the main things was the Universal Healthcare Commission needs to be not just interagency membership, that it does need, acknowledging that a huge, large work group such as this work group may not be as functional, but some representation needs to be on that body beyond that, consideration also for expertise, that's really integrating that stakeholder voice into the actual commission. We had so broadening it and having them sit on it. There was some discussion about how to make the consumer voice well heard, but without any one representation. Particularly, one person can't always represent all voices there, but coming up with some sort of ombudsman or something that would represent that various consumer voices. I think, again, I think the other issues was, filling in the gaps would be broadly a good idea, and putting a much more heavier emphasis on it would be important in documenting this, and also highlighting, which wasn't on that actual diagram itself, but is in some other thinking about it, the work groups and the areas that need to be worked on are clearly articulated under that commission.
Thank you. So I think still some areas, it sounds like there was a decent amount of consistency across the groups, but there's still some areas of divergent perspectives. around fundamentally which model to pursue, although this this proposal is agnostic to whether it's A or B, so we should clarify that. But also, it sounds like there's some divergence around whether the commission should or should not include stakeholders. So we'll definitely capture that. And then some divergence around timing and how these steps should be laid out. But I feel like it was a really productive discussion. Thank you everyone for both taking the time to review in advance and providing such helpful feedback. Just going to run through our action items in our closing minutes here. You should be expecting an email from me with the document that I promised you that Optimus has put together, centered around expenditures and revenue sources. And I'm going to ask for you to submit any questions by next Thursday, November 5th, end of day. Optimus is going to put together a recording and a document answering your questions. And so we'll get that out to you as soon as possible. You should also expect, and I'll mention the request that came up early in the meeting, but for now you should expect the draft report on November 18th. A reminder that Aaron asked a question of if there's a way to break that up in chunks, so it's not something that first of all that you'll have to take it at once, but I also gathered from his point, if there's places where we still need to do some tweaking, it would be helpful to have it broken up in chunks. So we're going to be meeting tomorrow. We'll raise that question. As I said earlier, no commitments on that now because we are in a very tight timeline, but I will get back to you on the answer to that request. Did I miss any action items or next steps? Liz, anything else? All righty, well, everyone, oh, Bevan, yes, here, you get the last word and then we're gonna break. Yes, Bevan.
So just one point of clarification in the pre-recording from Optimus, are they also gonna outline the savings? Because I think that's a really important component to understand. And then my other just kind of comment is if there's still a fair amount of dissent within our group broadly around choosing option A, I would love to hear those voices and understand why you feel that way, and would love to hear kind of an outline of why that is for you. So just putting those two things on the table.
Jared, do you want to answer Bevan's first question?
Yeah, so the models, at least the information that's coming out, it's fairly comprehensive. It'll include for you cost expenditures, differences from the status quo, so you could call that savings. We also look at the revenues in terms of what is going to be required and go into some detail around longer term trends, if you would, or longer term expectations for what the cost and savings of the program would be over a 5-year period. So I think it'll provide some of those items that you noted.
And then Bevan, to answer your second question, I know certainly in the main room there was a pretty robust discussion about people's feelings about the different options, but I also think we can go back to our June meeting, I think our August meeting. I'll have to go back and look at the recordings, but I think there's a few places where concerns or questions about the different options have been surfaced by different members of the work group. So I think those will be good places to reference to answer your second question about why people have varying perspectives. And then finally, I think that report will be able to synthesize all of that so that you don't have to go back and review every meeting recording. At any rate, we are here at 4 o'clock. It was a pleasure as ever to spend the afternoon with you. I continue to wish you all good health and wellness, and expect some emails from me shortly. But again, thank you for your commitment, your participation, all of your homework that you did in advance. Very good discussions today, and we really appreciate your time. And we'll see you soon. Take care, everybody. Bye-bye.